It's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered. And in last week's episode, I answered another question in this series of questions from our client, Robert. And the question last week was part 8 of my 68-year-old mother is in intensive care with gastric perforation and she's not waking up after the surgery. Will she need a tracheostomy? You can check out last week's episode by clicking on the link below this video. You can find previous questions answered from Robert in part 1 to part 7 again. I put some links below this video in the written version of this blog. And if you're watching this on YouTube, click on the link below this video that directs you to our website where you can find all the other episodes. So in this week's episode of Your Questions Answered, I want to answer the next question from my client Robert, which are again excerpts from email counseling and consulting sessions with me. And the question this week is part 9 of my 68-year-old mother is in intensive care with gastric perforation and she's not waking up after the surgery. Will she need a tracheostomy? So Robert continues with his mother's situation below. Robert writes, "Hi Patrick. Here are more questions because of all the things that have been happening in the last 24 to 48 hours with my mum. First, assuming that the kidneys continue to deteriorate, the next logical step does seem like dialysis. Doctors are sounding like that's not something they would advocate for or recommend. But I don't understand the downsides to this other than the cost. Number 2, I know you are familiar with the US healthcare system, but do you know if hospitals usually address patient treatment based on whether they are on private insurance or government insurance? Number 3, if they are influenced by that, is there an appropriate way to communicate to the hospital staff that we are willing to pay out of pocket for any costs, should that be required? Number 4, my sense, based on interacting with the ICU team, is that if we show conviction that we'd like the dialysis done, should it be necessary, that they will follow our wishes, but they may try to talk us out of it. Number 5, we asked the question whether there's any benefit to doing dialysis sooner rather than later, for example, before irreparable damage happens to the kidneys. Their response was that studies generally show that there's not that big of a difference doing it early versus doing it a few days later in the process. What do you think? Number 6, compared to other procedures she's had, where does dialysis fall in terms of severity of the procedure and what's involved? Number 7, right now the doctors have said we should give her a couple of days to see if she breaks through on one or more fronts. Kidneys starts picking up again, breathing improves, etc. But if things don't get appreciably better, then we need to sit down and have a tough conversation. Number 8, my instincts tell me that though the staff are well-intentioned, at some point they become reluctant to invest more resources into a patient that is showing a downward trajectory and may not recover. They're solving for average outcomes. We are solving for our mum. I'm not accusing them of being financially motivated, but I understand the practicalities of having finite resources and wanting to do the best for the most number of people. Any guidance on how to balance this mismatch in incentives? As it turns out, we have the financial means to pay for the healthcare services required should we need to pay directly ourselves. All information I'd appreciate. This is probably the most disheartened the family and I have been because all things seem to be pointing downwards and the staff are hinting that we may not want to proceed with the dialysis. Thank you for your help. From Robert." So here is my response. "Hi Rob, please see my answers to your questions or listen to my answers to your questions now. So first, you are asking, assuming that the kidneys continue to deteriorate, the next logical step does seem to be like dialysis. The doctors are sounding like that's not something they advocate for or recommend. But I don't understand the downside to this other than the cost. So here's my response. I don't understand, Rob, why they wouldn't advocate for dialysis. Besides critically ill patients' lungs failing and needing ventilation, the kidneys are the next organ that's failing in critically ill patients. Hemodialysis is being used across the board in many critically ill patients in intensive care, and is the next most commonly used major life support mechanism besides ventilation and inotropes or vasopressors for low blood pressure. I understand that the doctors are despondent, and I will address their attitude a bit later. The reality is that many critically ill patients in intensive care go into acute kidney failure. They go on dialysis, and in about 90% of all cases, the kidneys do recover if patients survive their critical illness. Your next question was that I know you are familiar with the US healthcare system, but do you know if hospitals usually address patient treatment based on whether they're on private insurance or government insurance? Well, as you know, I am familiar with some of the aspects of the US healthcare system. We are dealing with clients in the US all the time, each and every day. Hospitals will definitely base treatment on whether a patient is having private health insurance or government insurance. From experience with other clients, I would strongly argue and advocate that having private health insurance is of benefit in the United States, the UK, and Australia. Your third question is, if they are influenced by that, is there an appropriate way to communicate to the hospital staff that we are willing to pay out of pocket for any costs, should that be required? It may well be a strategy that you want to pursue, Rob. Sometimes it can also help if I can help you position your mother's diagnosis, her prognosis, as well as her care and her treatment. I.e., for other clients, we are talking to doctors, nurses, and we also dial into family meetings over the phone if they want us to. This would be based on experience, but also knowing what goes on behind the scenes and behind the curtains in intensive care. I can give you much more information on this strategy if you want to either let them know that you are happy to pay for treatment or if you want me to talk to the doctors. Number 4, you say, my sense based on interacting with them is that if we show conviction that we'd like dialysis done, should it be necessary, that they will follow our wishes, but they may try to talk us out of it. So, here's what you need to know, Rob. If your mother goes into acute kidney failure, she will need dialysis. Given that there are currently no treatment limitation orders as far as I'm aware from your communications, it would be negligent of them not to offer dialysis in case of acute kidney failure. Your next question was, we asked the question whether there's any benefit to doing dialysis sooner rather than later, i.e. before irreparable damage happens to the kidneys. Their response was that studies generally show that there's not that big of a difference doing it early versus doing it a few days later in the process. What do you think? Generally speaking, I totally agree with this, Rob. From my experience, the kidneys are the most forgiving major organ, if you will, and unlike in respiratory or heart failure, the kidneys can wait a couple of days. Given that the medications like diuretics like furosemide or Lasix don't seem to work, the next logical step is to get the dialysis going ASAP. Trying diuretics first is the right thing to do, and if it doesn't work, then get the dialysis in. They seem to be following a normal pathway there unless they have been trying diuretics for many days, usually for more than 3 with no success. Your next question, Rob, was, compared to other procedures she's had, where does dialysis fall in terms of severity of the procedure and what's involved? In intensive care terms, Rob, this is a quote-unquote normal procedure. Your mother will need a vascular catheter, which is similar to a central venous catheter that she will already have. Therefore, the biggest risk is probably in inserting another venous catheter and then get the dialysis going. It's certainly adding in another layer of complexity. However, it's a layer of complexity that ICU doctors and nurses should be well trained and well experienced in. They will need to closely monitor your mother's electrolytes once she's on dialysis, her potassium levels in particular. Your next question was, right now the doctors have said we should give her a couple of days to see if she breaks through on one or more fronts, kidney starts picking up again, breathing improves, etc. But if things then don't get appreciably better, then we need to sit down and have a tough conversation. Here's what you need to know about this, Rob. Have they actually used those words, tough conversation? I would strongly argue, let's wait and see. From everything you are describing thus far, your mother is currently requiring two major forms of life support. First, mechanical ventilation with a tracheostomy, and number two, low doses of inotropes and vasopressors for low blood pressure, with a view of being off inotropes or vasopressors if I interpret your comments correctly. There is a potential for a third form of major life support to be added in soon in form of the dialysis. If inotropes and vasopressors were high and oxygen on the ventilator remained at 100% for more than 72 hours, I would be extremely concerned. Intensive care teams tend to be very negative by nature and by default. It helps them to stay in control of the outcome and also the meaning they want to attribute to a particular situation or critical illness. I have written about this extensively on my blog, and I have put some related articles and videos below this video in the written version of this blog. For example, you can read up the 5 things the intensive care team hasn't told you when your loved one is critically ill in intensive care, or 5 powerful things you need to do if the intensive care team is negative when your loved one is critically ill in intensive care. I strongly encourage you to check out those articles and videos. Now, your next question, Rob, is, my instincts tell me that though the staff are well-intentioned, at some point they become reluctant to invest more resources into a patient that is showing a downward trajectory and may not recover. Now, Rob, this is a really good observation. You're right on the money there. So then you say that they are solving for average outcomes, but you are solving for your mum. You're not accusing them of being financially motivated, but you do understand the practicalities of having finite resources and wanting to do the best for the most number of people. Any guidance on how to balance this mismatch in incentives? As it turns out, you have the financial means to pay for the healthcare services required should you need to pay directly yourselves. Now, Rob, you are a very good observer. From everything you are describing and telling me, I'm certainly very concerned about your mother's situation. However, I still don't think there's any need to panic. I have seen those situations over and over again. Of course, being critically ill in intensive care is as close to death as anyone can probably come during their entire lifetime. However, please also keep in mind that, quote-unquote, only around 6 to 10% of patients in intensive care don't leave intensive care alive. You don't need to accuse them of being financially motivated. Every ICU has a financial budget, and the medical director and the nurse unit manager tend to be in charge of a budget that they are accountable for. Every communication in intensive care, including communication with families in intensive care, is implicitly or explicitly around the elephant in the room, and that's the dollars. I believe that trying to help you to A, get perspective around critical illness and intensive care, and B, trying to help you position your mother's diagnosis, prognosis, as well as her care and her treatment are the right positioning tools to begin with. This is probably your biggest leverage tool in all of this. I hate to say it, but unless a family is really prepared to do what you and all of our other clients are doing and get support, intensive care teams will get what they want because they simply know what to say, when to say it, how to say it, and what not to say. I've seen it over and over and over again. My best advice to balance this quote-unquote mismatch of incentives is really to call them out on it if you need to, but it's too early to do that, I believe. To give you a quick example, the client that we've been working with since the end of November last year and just left ICU live last week was on public insurance or government insurance, and the family didn't have the means to pay for private treatment. Our fees came in at a much lower rate for the family compared to sending him to a private hospital or ICU, where they would have loved to treat him, of course. We were able to help the family by bringing in our clinical experience, but also our advocacy service, as well as knowing what's happening behind the scenes in intensive care. We can easily leverage that knowledge for the benefits of our clients and help them to get the outcomes that they want and deserve. Next, you are saying that all information is appreciated. This is probably the most disheartened the family and I have been, because all signs seem to be pointing downwards and the staff are hinting that we may not want to proceed with the dialysis. Now, here is what you need to know about this, Rob. Critical illness and intensive care has many ups and downs for families, and especially since you've been dealing with this situation since December, I believe, you and your family's sanity is as important as your mother's well-being. Yes, your mother has gone backwards and she's facing many challenges. But she's not facing any challenges that any intensive care doctor or intensive care nurse hasn't seen before. Nobody can be sure of any outcomes, but I can see that if the antibiotics are working and she's coming off the inotropes and vasopressors and oxygen on the ventilators coming down, she is making slow progress. Intensive care is often 2 steps forward and 1 step back, and even though I might sound like a broken record, patience, persistence, and staying positive. Take 1 day at the time and make sure that you and your family keep looking after yourself. It's very important, if not the most important ingredient. Last but not least, you mentioned, in talking to the doctors, they were very despondent today. They reiterated that she's having issues with multiple organs and the kidneys are the most concerning. They seem really worried, and the prognosis that we've heard is that she has about 20 to 30% chance of making it through. Yes, your mother is having issues with multiple organs, namely 2, the lungs and the kidneys. Many critically ill patients in intensive care are facing heart, lung, kidney and liver failure. Now, again, your mother's situation is critical and she's very sick, but again, whenever there's life, there is hope. My advice would be to get the dialysis going as soon as possible. Hopefully they can continue reducing the oxygen on the ventilator and they can cease the inotropes and vasopressors. If they can achieve that in the next 48 to 72 hours, it would be a great achievement. If they can achieve that, it probably won't make them more positive in their outlook, and I believe I can give you perspective around that. Also, Rob, you can't control their outlook and their negativity, but you can control your outlook and you can control your response to their negativity. You're doing that already by trying to get perspective. I really hope this helps, Rob. I know this is a massive challenge for you and your family. You're doing great and you keep hanging in there. They are not the words I would choose for any situation really, but I also know that's how families in intensive care often feel. Also, try and make meaning out of this situation. I believe it helps. What do I mean by that? I'm a strong believer that things in life happen for a reason. What's the reason that you and your family are faced with this massive challenge? I don't know the answer, but I'm certain you'll find it if you keep digging. Most families in intensive care who don't give up have found their meaning. I'm really wishing you and your family all the very best, Rob, and we talk soon. So, how can you become the best advocate for your critically ill loved one? Make informed decisions, get peace of mind, control, power and influence quickly whilst your loved one is critically ill in intensive care. You get to that all-important feeling of making informed decisions, get peace of mind, control, power and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision-making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care, and how your critically ill loved one's treatment may depend on those competing interests. How to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. You'll get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You'll get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also check out our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Or you can call me, find international phone numbers on our contacts tab. Also, check out our ebook section where you get more ebooks, videos and audio recordings, and where you can also get one-on-one counseling and consulting with me via Skype over the phone or via email by clicking on the products tab. This is Patrick Hutzel from intensivecarehotline.com, and I'll see you again next week in another update.